denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra, di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione, tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or their family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie al loro per esserlo il meglio.
I'm an anesthesiologist and I'm proud to be an intensivist. We, intensivists, are working together to fight COVID-19. Together, we are intensive care medicine.
Hi, I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist. I'm proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waale and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
Good afternoon, everybody. My name is Martin Balik. I'm intensivist performing intensive care currently in Prague in Czech Republic. And it's my pleasure to invite you this afternoon to listen to application of echocardiography and ultrasound in COVID patients. The topic of the webinar is a quick 5-minute echo and ultrasound exam in our unhappy COVID-19 patients. And as you noticed, echocardiography and ultrasound has become one of the mainstay in critical care diagnostics. And today we have a wonderful opportunity to listen one of the prominent figures in the field of critical care ultrasound and echocardiography, Professor Antoine Viard-Baron from Boulogne. And I'm happy to see you, Antoine, and I'm handing over to yours, and I'm looking forward to your presentation.
Okay, thanks a lot, Martin, for your nice introduction. I hope you are good. And I want to tell you, my friend, that I am really happy to share with you these few slides, just illustrating why and how to use echocardiography in patients with COVID-19. You will see that my lectures in 2 parts. You will have first part some general slides about why to use echo in general in critically ill patients. And in the second part of my presentation, I will show you some key informations about what we know about the COVID-19 and the echo pattern. And I have to say in preliminary information that right now we do not have so many data already published on that topic. So first, just to show you what we had to manage in the Great Paris during the COVID-19 pandemic. And you have here in blue the number of hospitalization in the hospital, I mean outside the ICU, from beginning of March to the beginning of May. And you can see that we had at the top more than 3,000 patients admitted outside the ICU in the hospital for COVID-19. And you have here on the right the number of patients that we had to manage in the ICU. So I mean critically ill patients. And you can see that at the top, we had more than 1,000 patients. It was exactly in the APHP group, my group, it was exactly 1,200 patients. And you can see the dotted lines just represents the number of beds that we usually have to manage critically ill patients. And so you very well understand what we had to deal with, and we have to double or more than double the number of beds to manage this huge wave we saw. So first, why performing a critical care echocardiography in COVID-19 patients? That's a key question. First of all, I want to show you two small studies, maybe not very rigorous in terms of evidence-based medicine, but which suggest that when you perform a critical care echocardiography in a critically ill patients, you may maybe improve the outcome. The first one was done using administrative data from many US hospitals. And you can see that especially doing an echo in patients with chronic heart failure, CHF, or in sepsis, or in case of acute myocardial infarction, was associated with an improvement in the outcome. And you have this recent study we did using the MIMIC3 database. And so once again, with many limitations, it was only focused on patients admitted in the ICU for septic shock. And you can see two groups of patients. The first group, the patient had an echocardiogram during the initial stay in the ICU, while the second group did not benefit from any echo. And you can see if you look at this statistical analysis, and especially in patients who required mechanical ventilation and vasopressor, or in patients with a high SOFA score, higher than 10, you can see that the use of echo was associated with an improvement in the outcome. It means that in this specifically very severe patients, doing an echo had a direct effect, or this study suggests that doing an echo had a direct effect on the prognosis of your patients. And this is something not so difficult to understand, as you will see some pictures when you describe how the heart is moving, how the heart is contracting. That's probably better to adapt the treatment and to give the right treatment for the right patient. So in COVID-19, we know that many patients develop shock, probably in part, but not only, due to the cytokine storm, and probably also in some patients because of co-infection. And you can see a study that we did in 4 centers from Paris. It's just submitted and not already published, but you can see 379 consecutive patients admitted in the ICU for COVID-19. And you can see that indeed 44% of the patients required vasopressors, at least initially or just after the admission. So it was a huge number of patients with circulatory failure. And we know that in this situation specifically, echocardiography is really the core of the monitoring and of the management. And this is something that everyone agrees. And I just remind you this statement published many years ago, just to show you that indeed after a first type of fluid responsiveness, maybe because the CVP is very low, so you have initially to resuscitate the patient, you can see after this first step, very quickly, you have to perform an echocardiography just to look at how is the right ventricular size and the right ventricular function, how is the LV function, how are the size of the LV, and so on. And just to categorize the shock. Maybe it's an obstructive shock, a cardiogenic shock, a septic shock, a septic cardiomyopathy, or maybe you have still some hypovolemia that you need to correct. So if you do the analogy between COVID-19 and sepsis, once again, maybe because of this cytokinic storm, you may have 4 different situations if you perform an echo. So here I show you a transesophageal echocardiography in a patient with a septic shock. And you can see the first pattern is that you have an isolated left ventricular systolic dysfunction. Here, this is the transgastric view, and here the mid-esophagus view. You can see the right ventricle is non-dilated, and the left ventricle poorly contracts. It is the first picture. The second one, this one, you have now a very good left ventricle, hyperkinetic, but the right ventricle is dilated, and you observe a paradoxical septal motion. So you know that there is a right ventricular failure and probably due in part to increased afterload. The third situation, and here this is an apical four-chamber view, so of course you can do transthoracic echocardiography. You can see a poor contractility, a poor function of both ventricles. The left ventricle contracts very bad, and look at how was dilated the right ventricle. So this is the third pattern. You have a biventricular dysfunction. And finally, you may have the last pattern, which is an isolated left ventricular hyperkinesia. You can see no paradoxical septal motion, no RV dilatation, but some hyperkinesia, usually due either to hypovolemia, but here probably due to profound vasoplegia. And so this patient probably requires more norepinephrine infusion. And I told you that, of course, using the echo and especially the TE, you are also able to look at the volemia of your patient. And this is here an upper esophagus view, a longitudinal view of the supravena cava. You have here the right pulmonary artery. And we combine the 2D with the time motion study. Sorry. And you can see here with the respiratory trace, a cyclic collapse of the supravena cava during each tada ventilation. Very suggestive in this study that the patients probably requires more fluids. And you can see after fluid expansion that the patient was much better in terms of blood pressure, lactate, and so on. But also, if you look at now the supravena cava, you cannot visualize anymore any collapse during tada ventilation. And so probably the resuscitation here was now optimal. The second reason why you have to perform an echo in COVID-19 patients is because they frequently develop an acute respiratory distress syndrome. So we all agree that in most of cases, this ARDS is unusual. It's not a very typical one, but if you apply the Berlin definition, that's by definition, this is an ARDS. And you can see once again in the case series of a little bit less than 400 patients that I show you, in 68% of cases, patients develop acute respiratory distress syndrome with a PNF ratio at day 1 around 127 millimeters of mercury, so which is a moderate acute respiratory distress syndrome. And what we know in this specific situation is that if you just forget any sepsis mechanism and so on, you have a direct effect of the ARDS on the right ventricular function through the effect of the disease and the pulmonary and the ventilation, on the pulmonary circulation. And this is something that we initially described in this study, where the incidence of acute cor pulmonale was around 22% in more than 700 patients ventilated for usual or typical ARDS, once again, which is not exactly the case for COVID-19 patients. You can see in this study the main risk factors for developing right ventricular failure, which was pneumonia. It's the case for COVID-19, which was a PNF ratio below 150, which was very frequent in COVID-19 patients. But two factors probably not very well observed in this very specific patient. First, a high driving pressure, because most of these patients, at least initially, had, let's say, not so depressed lung compliance, and the PCO2 at least higher than 48 millimeters of mercury. And once again, because the patients were not so difficult to ventilate, at least initially, they did not exhibit significant hypercapnia. So we will have to understand in the future whether this patient could develop at the same level some right ventricular failure related to the effect of the disease and the respiratory settings on the pulmonary circulation. And you have here, according to the number of risk factors, the incidence of the right ventricular failure, you can see that if you have the 4 risk factors, the risk is very high. 70% of cases, 70% of patients developed acute cor pulmonale. I show you a typical example, once again using TEE. This is a mid-esophagus view. So the probe is around 30 centimeters below the dental arch. And you can see that the right ventricle is bigger than the left ventricle. The LV systolic function is in a supranormal range. The patient is tachycardic. And now if you move down the TE probe into the stomach, just to look at now the transgastric view with the short axis view of the left ventricle, you can see here the inferior wall, the anterior wall, the lateral wall, and the interventricular septum. You visualize very nicely this abnormal movement of the interventricular septum that we call a paradoxical septal motion. So the association of the dilatation with the paradoxical septal motion is the definition of the cor pulmonale. So we have only a few data about this sport right now published. This one in a very small series published recently in Critical Care by Philippe Vignon's group. You can see it was done in 18 patients hospitalized in their ICU for COVID-19, and they compare especially the incidence of acute cor pulmonale in this cohort of patients. They compare to patients previously admitted the year before because of flu and who develop, let's say, a typical or more usual acute respiratory distress syndrome. And you can see that they observe, and that's interesting, much lower rate of acute cor pulmonale in patients with COVID-19 compared to patients hospitalized for flu. You can see this is not significant, but there is a lack of power. But this is 17% compared to 48%. If you look at also this case series published in the COVID-19 cases section of the New England Journal of Medicine, you can see here 5 patients that they reported. They were admitted for a pneumonia related to COVID-19 in their ICU. And you can see that these 5 patients, they exhibited acute cor pulmonale. And you can see here, especially look at the line with intracardiac thrombus. You can see that 2 of them had, using the echo, thrombus into the cardiac cavities. So probably the cor pulmonale was related to a pulmonary embolism, or at least to some clot into the heart and into the pulmonary circulation. But you can see they were unable to visualize any clot in the 3 other patients. And so just to do the link between the previous slides and the one, which is that indeed many patients develop pulmonary embolism, and you can see that we don't know exactly if it's really pulmonary embolism, probably some of them, but in some patients it could be a thrombus directly occurring into the pulmonary circulation. And you can see here in our series that at the admission on the initial CT scan that we perform with a systematic injection just to visualize very well the pulmonary arteries, you can see that in 40% of cases, the patient has some clot, some thrombus into the pulmonary arteries. So what about now the different studies in COVID-19 reporting the main, let's say, clinical patterns of the patients in terms of these different kinds of pictures? You have this first paper coming from China. This is the Wuhan experience published in the Lancet journal. And you can see here, for instance, the percentage of patients who develop sepsis, respiratory failure, RDS, heart failure, septic shock, and so on. So just to tell you that it is not 191 patients admitted in the ICU. It was 191 patients admitted in the hospital for severe clinical status, but not all patients were critically ill. But you can see that in a large incidence of cases, the patient finally exhibited some cardiac failure or some ARDS, which, as I show you, is maybe able to lead to right ventricular failure. If you look at this other study published in the New England, just I show you this study, but probably that you heard that this study was very critical because this is the same first author that published the famous paper in the Lancet recently about the hydroxychloroquine, and there is some controversy about the reality of the data. But anyway, just to show you here, in the large number of patients, I want to show you that the congestive heart failure was significantly associated with an increased mortality rate, which is quite obvious. And this is something that probably you may detect using the echo, and maybe not prevent, but you may better treat if you have the echo available at the bedside. Probably the best study at that time about a large series of COVID-19 patients, because you can see this is more than 600 cases of patients hospitalized once again in China. You can see the mortality rate was very low, 9%, so it's not only patients hospitalized and admitted in the ICU, but once again in the hospital with some severe sign of pneumonia and so on. And you can see that's interesting because it's a large study about biomarkers and especially about troponin, just showing that when you have some acute myocardial injury or acute heart failure or multiple organ failure syndrome or shock, this was the main causes of death in these included patients. Of course, ARDS was also a main cause of death in this patient. It means that most of patients who died develop an acute respiratory distress syndrome. But you can see that probably most of them, they died because of acute heart failure, multiple organ failure syndrome, or shock. So how performing a critical care echocardiography in COVID-19 patients? So in the title of my lecture, it was a 5-minute echo study. So that's clear that it's a very good message to tell you that you have to do a very focused examination, echo examination. And this is true every day for all kinds of patients, but it was probably specifically true for COVID-19 patients because of the risk of contamination of the health workers first, and because we had a big wave with many patients, and so we do not have so many time to be in the room to perform the echo. And I just want to show you this study that we did many years ago, and our goal was to build a scoring system just able to validate the skills of our trainees in performing a transesophageal echocardiography to evaluate hemodynamics. And so it was interesting because in this scoring system that I do not show you because it's not the field of this lecture, we add some extra points. We had 2 extra points, which was only if the trainee was able to perform the examination in 10 minutes or less. And I think 10 minutes is really a key duration for this kind of examination. Just to tell you that 10 minutes did not include the introduction of the probe. So it was just after the introduction of the probe. In 10 minutes, you have to get all the information for the hemodynamic adaptation. And just to show you that although the expert was able, of course, to do the examination in 10 minutes or less, it was not the case of the trainees. You can see after 1 month, it was 24 minutes. After 3 months, it was 21 minutes. And interestingly, after 6 months, it was 16 minutes. But you can see that some of them, 16% at 6 months, were able to complete the examination in less than 10 minutes. And so I think really it's a very important message. Do not pass too much time into the room, into the patient if you use the TE probe, just to look at and to get the informations. Just I want to complete to tell you that because of the high number of patients we had to manage, usually in my unit we have 2 echo machines with 1 TE probes, and here we had 4 echo machines with 2 TE probes, and so we were really able to multiply the echo examination in this patient and to perform serial echo examination. You have different approaches, of course, when you use the critical care echo. You have the one that we call the basic critical care echo, which is very focused. You have to answer to very basic questions. For instance, is there severe LV dysfunction? Usually this is by eyeballing. This is a qualitative evaluation. The second question, is the right ventricle severely dilated? This other one, is there a moderate or large pericardial effusion? Or is the patient likely to be volume responsive, just to look at how is the IVC? Let's say congestive, so the patient is very unlikely to be volume responsive, or virtual or very small, the patient is likely to be volume responsive. And finally, using color Doppler, is there any evidence of severe mitral or aortic regurgitation? So you can see that this is very focused, and usually this is based only on transthoracic echocardiography. What about the other approach, which is more suitable for hemodynamic evaluation, monitoring? This is the advanced critical care echo, and usually you have to perform a transesophageal echo. And I want just to give you a key information that probably you know, is that most of the COVID-19 patients, actually they had, let's say maybe not obesity, but increased weight, that this is something we know may limit the adequacy of the transthoracic echo to obtain perfect views and to have the good information. So probably, especially in this kind of patient, the TE approach could be interesting. And so here the questions are a little bit less simple and probably less qualitative, but much more quantitative. And you have to know how are the LV filling pressure, elevated or non-elevated. You have to find any arguments about any increase in right ventricular afterload, for instance, using the tricuspid regurgitation flow and measuring the maximal velocity, or maybe you have to look at whether there is a cardiac tamponade with the diastolic collapse of the right ventricle. And of course, now for the volemia status, you have many information that you may get from the echo. First, of course, this is the one I like very much, as I show you, is the respiratory variation of the supravena cava, but you may also have many other information, and especially, for instance, whether there is some respiratory variation of the LV stroke volume. If you look at the respective advantages and disadvantages of transthoracic and transesophageal echocardiography, I want just to show you this paper we published a few years ago with many experts worldwide from different societies. I want just to show you the disadvantage of TE, that's clear that it is difficult to perform repeated studies. It requires a strict protocol to clean the probe. That's specifically true for the COVID-19 patients, but I have to tell you that since many years, we systematically put a condom on the TE probe, and so it increases, I think, the cleaning of the probe, and it shortens the cleaning process. And finally, of course, this is not completely non-invasive. This is minimally invasive, but you can see that the most severe complication, which is esophageal perforation, is very rare, providing that you do the echo in mechanically ventilated patients and sedated patients. If you look at the disadvantage of the transthoracic approach, once again, as I told you, the views may be limited by patients' factors, and especially obesity, which was very frequent in this pandemic. You need, and this is very well demonstrated, a longer training period than TEE. TEE is very, very easy, while to have a very accurate evaluation using the transthoracic approach, you need to be more trained. And as a consequence, this is much more operator dependent than the transesophageal echo. Look at about the protection of the TE probe. You have this small correspondence which was published a few weeks ago. And you can see that here it was in Canada. So this is during the operating room, but in a patient who had surgery in emergency, but who had COVID-19. And you can see that they used the laparoscopic camera sleeve just to put the big block and the TE probe inside to protect the device. And so they were able to perform the echo by protecting very well the device. But be careful, don't forget to protect yourself, because you are very close to the mouth of the patient, even though the patient is intubated and mechanically ventilated. So some very preliminary data from my Siegel Center, which is my unit. It's not really data, it's just to show you some typical patterns that we had observed. Just to tell you that we recorded the echo in 81 patients admitted in our ICU. And you can see that globally, we did 219 critical care echocardiography, which is around a little bit less than 3 critical care echo per patient during their ICU stay. It's not so much because, as you know, the length of stay this patient was very long. And I have to tell you that my last patient left the unit just today this morning after 68 days in the unit. So most of the echoes that we did were performed at the initial, after the admission and during the first days in the ICUs, where the situation is especially critical. And you can see that we did a little bit, we did 109 transthoracic echocardiography and 110 TEE. And I have to say that many patients had both one TTE, maybe one day, and one TEE, maybe another day. Look at, for instance, this kind of first pattern. So I hope you visualize well the video. So it was a young lady, 17 years old, which who was admitted in the unit at the end of April, beginning of May, for what we called, and probably you heard about that, a Kawasaki-like syndrome. And indeed, she was admitted for a very severe cardiogenic shock, and she had encephalopathy, and we had very quickly to sedate, to intubate, and to mechanically ventilate this young lady. And you can see the TE, the right ventricle was non-dilated, and you can see that the left ventricle very poorly contracts. And this is here the transgastric view. You can see a very bad left ventricular systolic function. If you look at the superior vena cava, not exactly on the same view that I like to obtain it. You can see maybe if you have some, if you do some TEE, you can visualize and recognize here the right atrium and with the entry of the superior vena cava into the right atrium. So we are a little bit too low. It's not exactly an upper esophagus view, but we were able to visualize absolutely no respiratory variation of the superior vena cava. You have inside the central venous catheter into the superior vena cava. So it was very well expected because this patient was congestive, with a pattern of cardiogenic shock. Another illustration that we had, you can see here this patient in shock. The left ventricle was hyperkinetic, small size. You can see the right ventricle was dilated. And look at the parasternal short axis. you may visualize a very nice paradoxical septal motion. So this patient had an acute cor pulmonale. And if you look at in the same patient here, this is the upper esophagus view at 0. You recognize here the ascending aorta, the superior vena cava, and the right pulmonary artery. You visualize here a thrombus into the right pulmonary artery. And here, if we turn a little bit the probe, you can see the right pulmonary artery, which was enlarged at the bifurcation of the lobar arteries. And you can see here the clot into the pulmonary circulation. So in this patient, in the same time, we were able to understand why the patient had a shock. It was due to right ventricular failure and cor pulmonale. And we had the explanation of this obstructive shock, which was some clot into the right pulmonary artery. Another example here, you can see the patient was tachycardic, the LV contracts very well, the right ventricle is much bigger than the left. This is the mid-esophagus view. Here, this is the transgastric view, the short axis view of the left ventricle. You can see some paradoxical septal motion. And you can visualize here, if you look at into the right atrium, you have this image, which was actually a clot just at the extremity on the central venous catheter. So once again, this patient was in shock because of right ventricular failure related probably to a clot into the pulmonary circulation, because here you visualize the clot into the right atrium. So just to conclude, I want to tell you that in the future, we really need to collect a lot of data regarding the echocardiographic studies in patients admitted in the ICU for COVID-19 and especially for pneumonia related to COVID-19. And this is a project that we want to conduct with the echo group of the cardiovascular section of the European Society of Intensive Care Medicine. You have most of these fantastic people here. We recently published this systematic review about critical care echo in Annals of Intensive Care. And you can see that we will try worldwide to collect all the echo that we did in COVID-19 patients, just to be able to report our experience and the main echo patterns. And maybe we will find some links, some relationship between respiratory settings, let's say, why not the PEEP level or something else, and the right ventricular function. And I want to conclude with my last slide, just to thank my team. This is just a very small part of my team during this pandemic, because we had to double the number of health workers in the unit. And just to show you the last patient that left the unit today morning to go for rehabilitation, you can see that he left the unit with the tracheostomy and still ventilated with a small ventilator. I thank you for your attention, and we have, I think, some time for questions.
Thank you very much, Antoine. Very comprehensive and nice talk. I see some questions coming up. As you prefer for standardization the transesophageal approach, there's always a concern about the disinfection of the equipment and disinfection of the probe, particularly in COVID-19 patients. And the question is whether you disinfect the whole device or whether you are satisfied with the protective sheath or with the probe disinfection only.
We always, I mean, whatever the situation, not only COVID-19, we always combine the protection of the probe with the condom during the examination, plus a cleaning process with some specific product during 10 minutes that we have to put the probe in. And we know very well that this virus is very sensitive to this kind of product. So I mean, I am more, or maybe more concerned not for the TE probe, but for the echo machine, the EKG leaks, and so on. And this is why probably on my cases, you did not show many EKG trace on the screen because we did not use this kind of EKG trace due to some concern about contamination and so on, and because we do not have so much time to put everything on the patient, and we really wanted to focus our examination to get very quickly the most important hemodynamic informations.
Okay, besides disinfection and some hygiene protection of the patients and of the devices, if you prepare TEE, would you perceive a limitation in respiratory insufficiency and particularly in some comprehensive assessment of the patient's lungs with ultrasound? Or what do you think about the concept of combination of echocardiography and chest ultrasound, particularly when diagnosing COVID patients and monitoring the progress?
I think the concept is very fascinating, and obviously, ideally, you have to combine both because, as you know, it's very good to have information about lung aeration and just to combine this information with the cardiac function and especially the right ventricular function. But honestly, if you look at the literature, there are only a few or maybe no study just rigorously evaluating this kind of approach, which combine the lung ultrasonography and the echocardiography, just to help managing the patient. But I fully agree with this question or with this comment.
Okay. A question from an attendee. How would you distinguish COVID-19 myocarditis, particularly from myocardial infarction?
First, I think it's a good idea to look at the EKG. This is the first step. I mean, if you do not have any suspicion of a myocardial infection on the EKG, it's very unlikely that the patient has actually a myocardial infection. The second step using echo is, of course, to look for segmental wall motion abnormality. Usually when you have a myocarditis or a Kawasaki-like syndrome, as I show you, if you remember the slide, you have a very global poor left ventricular contraction, which is absolutely not the case when you have a myocardial infection. Usually you have one segment which is hypokinetic or akinetic, and the rest of the heart of the left ventricle is usually normally or even hyperkinetic.
Okay, and if we think more broadly about the differential diagnosis, what we see in my COVID patients here is, for example, stress-type cardiomyopathy and a septic cardiomyopathy with even some pattern of Takotsubo in sepsis on top of COVID-19. And could you comment on a primary COVID-19, or have you seen actually primary COVID-19 myocarditis, which is quite rare, as compared to those secondary heart problems like stress cardiomyopathy or septic cardiomyopathy?
I have to say that I did not visualize any typical pattern of Takotsubo syndrome or stress cardiomyopathy. I mean, I did not visualize any apical ballooning with hyperkinetic basal part of the LV. So I don't know if it's if we can really say that you have a myocarditis directly related to the COVID-19. But what we saw indeed in two young ladies is this kind of picture that I show you with a pattern of myocarditis. The PCR was positive, but when we discussed with the family, these ladies were in contact with sick member of the family a few weeks before. So probably it was just a positive PCR, but it was more probably reflecting a post-infectious process than really a myocarditis due to the virus. But as you know, there is a lot of research in the field, and this is something not very well described at that time.
Yeah.
And you, sorry, Martin, you observed many patients with a pattern of stress cardiomyopathy?
Yeah, we had actually one patient on where we converted from VV to VVA ECMO, a COVID-19 patient with a typical apical ballooning and stress type cardiomyopathy as we concluded it. So I must say this is a secondary insult to myocardium, and I haven't seen during this coronavirus season a proper patient failing with myocardia inflammation of COVID-19 that is myocarditis, which is, to my knowledge, quite rare to find.
I think we know that there is, if you look at the paper in the European Heart Journal that I show you, the large series of patients, we know that there is probably a direct effect of the virus on the heart because using the troponin serial measurements of troponin, they were able to demonstrate an increase in troponin in many patients. So probably you have some injury, direct injury of the virus on the heart, or the consequence of the virus. I don't know exactly.
Well, I think it's a generalized endotheliitis, and it's probably even the endothelium of the coronary vessels. So you would be able to see even maybe some thromboembolic changes in those patients in the coronary vessels. So it's something which may come as a direct injury to the cell or to perfusion of the cell and or myocardial cell. There's a question from an attendee about thromboembolic problems with coronavirus patients. So what would you do if you find thrombi in big pulmonary vessels and in the right atrium? So I understand that the question can be also put, would you indicate a patient to Trendelenburg procedure if you see a big thrombus?
So first, if you forget, it's a good question and difficult answer. If you forget the COVID-19, and if you just look at the literature about this kind of situations in usual patients, we do not have so many studies allowing us to recommend something to do specifically. We probably have some data suggesting that it's better in this case to propose thrombectomy, so cardiac surgery, compared to heparin alone, of course, or even thrombolysis. In COVID-19, I don't know how to answer to the question, because after managing so many patients, I think this is completely not applicable to propose this kind of patients for cardiac surgery. So I will propose probably not to do anticoagulation alone, but to perform fibrinolysis, even, of course, if the patient is in shock, because as you know, you never treat a picture, you do not treat the echo, you treat the patient. So I mean, if the patient is very stable, this is just a picture, and so you have to monitor very rigorously and very cautiously the patient, but probably do not do any fibrinolysis.
Yeah, but in other patients, I would suggest the Trendelenburg procedure would be an option if you see a big thrombus in the heart. So it's always, as you say, judging a patient as a complex issue concerning the lungs and sustainability of the procedure, and also the skills of the cardiac surgeons. There's a question on a continuous HTE probe in COVID-19. Do you have any idea how would you actually change the precautions for the HTE, whether they would stay in place for 72 hours as they are certified, or do you use them at all?
So as you know, I used it many years ago just to test the system, and this is something that we published in Intensive Care Medicine Journal with Paul Maillot, Michel Slama, and I think also Philippe Vignon. But I did not using during the pandemic and the COVID-19. I think, to be honest, probably if you have this kind of probe available in your unit, it could be a very good approach. First, because this is single use, and second, because you may repeat the examinations anytime you want during the first 3 days, because as you know, after indeed 72 hours, the probe is over. So I did not do it, but yes, probably there is a room for this kind of device, for this kind of pandemic.
Yeah.
Did you use?
We use it for the study purposes, and we haven't done it on the COVID-19 patients. Our approach would be probably, as some attendees ask, we would probably start always with the transthoracic and combine with the lung ultrasound and chest ultrasound, because as most of the intensive care physicians know, the ultrasound and clinical pattern are forward by some, are ahead by some 48 hours ahead from CT and X-ray. So when you have the clinical pattern, you can add your transthoracic approach plus lung ultrasound, and you may have a reasonable accumulation of risk factors to say that this is fairly likely to be COVID-19 already before the PCR test arrives. So that would probably be our approach here. But I agree that the TEE is more standardized, and I can continue with some of the attendees' questions, and they would really like to have some practical tips and tricks, how you start at the which probe, actually which plane you start with at the beginning on the COVID-19 patients, and what would be the basic planes you would suggest. I think you mentioned it in your presentation.
So Martin, just could you repeat the question?
The question is, what would be your practical approach with the TEE, and how would you start the exam on COVID-19? You have a patient with a respiratory problem, and you say that you, for standardization purposes, you still prefer TEE.
Yes, for sure. But something very key, and maybe the question allows me to re-emphasize that aspect, is that obviously we do not perform any TE examination in spontaneously breathing patient with respiratory failure. It's absolutely not suitable and not good care. So when we do TEE, this is the most severe patients who require to be intubated and ventilated.
Yeah. Do you do echocardiography in prone position?
To be honest, we did it in the past, but during the COVID-19 we did not, and for a very simple reason is that for most of patients who were ventilated were turned prone at least once a day during 3 to 4 days or 5 days. First, and second, because of the huge amount of care that we have to do, and especially the nurses, but also the doctors, we organized the unit using, for instance, the surgeons who had nothing to do because we stopped any planned surgery, so except the emergency, and so they went twice a day in the unit. The first to put all the patients in prone position, and the second time after 18 hours to return the patient in supine positions. So because of that organization, and because we did not plan to do a specific study on that topic, because it was already done, we did not do any TEE during prone position. But you can do it. You have some studies, as you know, very well reporting that this is maybe not as easy as it is in supine position, but this is something that you can do, and you may get many information.
Yeah. I'm happy you mentioned papers coming up that patients with COVID-19 could have less prominent cor pulmonale than similar patients with the influenza. On the other hand, we are now supplied with the data on lots of thrombogenesis and even lung thrombosis and microcapillary thrombosis. And I see in my practice COVID patients having typically enlarged right hearts and problems even before being put on ventilator. So there's an important issue, and the issue is anticoagulation and thromboprophylaxis. So what's your approach? Or do you really see that the patients with COVID-19 would have less dilated right hearts and less pulmonary hypertension because of higher compliance, or vice versa?
Yeah. So it's a very good question and good comment. On one side, you will expect less right ventricular failure because the compliance is not so bad, at least initially, as I told you, and usually the patient was not so hypercapnic. That's true. But on the other hand, because of the high incidence of thrombus into the pulmonary circulation, you may expect an increased incidence of right ventricular failure. So I don't know where is the truth. And to be honest, I do not have any time to analyze very seriously my data on that way in the 80 patients that we had. And I think that the study that I show you is too small. It's a too small cohort of only 18 patients with COVID-19 to have a definitive conclusion.
Do you have any data on, for example, patients' findings on echocardiography related to body mass index in those patients with COVID-19? Because you often get obese patients around the age of 60, 65, males, hypertensive, diabetic. How does this impact on the right heart findings?
I can't answer to this question because once again, we are just starting to analyze our results. But once again, this is another argument which push in the direction that we could expect more right ventricular failure because patients who are obese have decreased compliance of the chest wall, may have chronic respiratory failure, restrictive, for instance, sometimes obstructive, and it could impact on the RV function. But I cannot answer exactly to your question.
Yeah. I must say, we've done a very good experience from the beginning, from early March, that we put all our COVID-19 critically ill on intravenous anticoagulation. So we, based on the data that were coming up, including the findings of microangiopathy with the elevated LDH and microthrombi, and it can change also the endothelitis and the right heart parameters. Also with regards to coming data that some 22% of patients can have a small pulmonary embolisms. What's your experience with treatment of these patients? Do you anticoagulate them, or could it have impact on your findings?
Yes, sorry, it was the second part of your question. Very quickly, we apply a very aggressive strategy of prophylactic approach, and it was mainly based in France by a paper which was published by the National Society of Homeostasis. And very quickly, they edicted the recommendation of how to apply anticoagulation from a prophylactic way according to a certain number of risk factors, let's say, for instance, the level of the D-dimers and so on. So according to the risk, we were able to apply usual anticoagulation or higher or more aggressive approach. So we did it very quickly.
Okay. When you see right heart failure in COVID-19, do you have any specific strategy with pulmonary vasodilators and the treatment of the right heart failure?
No,
and
we
monitoring with the echo.
Yes, the only drug that we used, but we tried to use, but it was not very successful. But once again, I did not have enough time to analyze the data. This is NO inhalation, so nitric oxide. On one side to increase the oxygenation and maybe to save time, just to give the patient some time to recover. And on the second aspect, maybe in case of circulatory failure related to right ventricular failure, to improve the right ventricular function and so improve the hemodynamics. So this is something that we did in many patients, but once again, the webinar is too close to the end of the pandemic, and so I cannot give you more scientific information about this aspect.
Okay. Thank you very much, Antoine. That was fantastic talk.
Okay, thanks, Martin. Take care. Thank you, everyone. I don't know how many people were connected, but it was really a pleasure to be with you. And take care, everyone. And I hope that we will be face-to-face very soon. Let's say in Madrid, I hope in December, or maybe in Brussels later. Anyway, we need a better time and a better period to see friends and to have a good meeting together. Thank you. Thanks a lot. Bye-bye.
Thank you. And I think the body virus wouldn't stop us to go to Madrid. I would like to thank everyone to staying to the end, and I'm very happy to conclude this session, which hopefully provided you some information on echo and ultrasound in COVID-19 and a hemodynamic management, specifically in those patients. I thank everyone for attending this webinar.